Hi, this is Nick Williford and Manos Brilakis presenting case 288 for the Manual of CTO Interventions. This is a case of a complex obtuse marginal CTO. The reason for the name the bridge will become apparent in a second. So this was a patient who was referred for PCI of this obtuse marginal lesion. There had been 2 prior attempts to recanalize that were both unsuccessful. There was also some disease on the right coronary artery. When we look at the obtuse marginal in the RAO view, we do see that's a very complex lesion with this little vessel that seems to be extremely tortuous. And although initially we thought there might be a continuous connection, retrospectively, this might represent a bridge, and this is what we will discuss. We advanced the microcatheter, we did a tip injection. The length of the occlusion is very, very short. And that was initially encouraging. We thought that would be a fairly easy lesion to cross. On a coronary CT that was done before, the occlusion length was called 4 millimeters. The proximal cap is clear, distal vessel is good quality, and the vessel is filling mainly antegradely through this structure, but also there are some collaterals coming from ipsilateral from the left. So our plan here was to go antegrade. If that didn't work, drew antegrade dissection re-entry, nice quality distal vessel. And if that did not work, try retrograde through the epicardial branch. Corsair microcatheter and several guidewires, and nothing would cross. Suoh black, filter XTA, Pala 200, even a Gaia Next 2, given the short length of the occlusion, nothing would go through. And once again, when we look at the occlusion in the RAO cranial view, it looks extremely complex. So retrospectively, this was a bridge, and that's why the wires don't go. The wires will want to track through this collateral. Moving on our plan, we decided to do dissection re-entry. We tried to knuckle, that didn't work. And then we decided to use the balloon-assisted subintimal entry. We took a 2.5 millimeter balloon and then tried to advance the guide wire. Sometimes it went into the distal circumflex, sometimes it tried to knuckle, but despite using multiple inflations, including a stiff wire, a Gaia Next 2 and Next 3 to scratch and go, we were unable to dissect. After multiple attempts, we decided to go in the retrograde through ipsilateral collaterals. This is a view of the LAD, because initially we thought that the lesion was filling through the LAD, but there is no connection. However, when we went into the diagonal branch, we do see the obtuse marginal filling, and this makes more sense since the diagonal is geographically much closer to the obtuse marginal compared with the LAD. Multiple injections to better understand the course of the collateral, and we can see here that the collateral is going to the distal LAD, so the patient also has a distal LAD CTO. But there's also collateral going backwards towards the obtuse marginal branch. For trying to cross those collaterals, the wire of choice is the Suoh 03, which is a 0.3 gram wire. It's very soft, atraumatic, less likely to cause dissection or perforation. Of course, here it was challenging to get into the collateral. Here we took a different course, going into a different branch, not into the collateral going to the obtuse marginal. Once again, this is the diagonal, this is the connection that goes to the obtuse marginal, but unfortunately in this case, the Suoh 3 has gone a little further down than this proximal turn. So we pull the microcatheter back. This is a Caravel microcatheter, and the Suoh 03 wire, it gets into the branch, as we confirmed, with contrast injection, and then very slowly with mild rotations, we do through the Suoh 3, take this bend, and now it's advancing close to the distal cap. So slow movement, the wire usually moves during the diastole, and then it often just finds the bend and then advances very rapidly towards the distal cap. The next step was to confirm that we're in the right location, and sure enough, we're into the obtuse marginal. However, we do see this staining at the proximal cap, and it's hard to know what this is, but most likely we created a little rupture of that little bridge that we're trying to knuckle wires through. The patient was having some chest comfort at this point, so we inflated a 2.5 balloon. We confirmed that there was no flow going forward. We do have a microcatheter under this balloon. And then we try to see how we can overcome this. Injection on the Carlino, we still see that there is flow going through this branch. Again, probably that little collateral got disrupted. The next step was to advance the microcatheter and then change the wire for something more penetrating. The Suoh 3 is not very penetrating. However, this was not feasible. And then we removed the Caravel and tried with a FineCross M3 microcatheter that has a very low profile. By doing that, we were able to advance the FineCross, which took the bends going into the obtuse marginal branch. So the lesson here is when there is a collateral that is not crossable with one microcatheter, one option is to advance another microcatheter, ideally a lower profile wall for epicardial collaterals. Once again, for epicardials, we never dilate them, which is something we sometimes do for septal collaterals. Retrograde tip injection shows that we're in the true lumen. There's kind of a bland distal cap. We could not go through this with a polymer-jacketed guidewires, so we switched for a more penetrating Gaia Next 3 guidewire that seems to advance along the course of the Antegrade gear. There's some overlap between the Gaia and the Antegrade balloon. Trying again, and different projections. We're having some resistance, which is good. That means we're trying to penetrate the distal cap, which was likely calcified and hard to get through. And then by advancing more, eventually we see that the wire advances further up. It's going along the course of the balloon. And then eventually, with a little more manipulation, it catches the tip and then knuckles. And then we have a knuckle. Now, Gaia is not the best wire for knuckle, but here it is a Gaia knuckle. Orthogonal view to confirm that there is good overlap between the two wires. And now it is a reverse cart. We need to advance the retrograde guide wire into the Antegrade guide catheter. To do this in the circ, we advanced a guide extension, 6 French coast, into the proximal circumflex and inflated several balloons, starting with a 2.5 and then a 3.0 millimeter balloon based on IVUS guidance. We did the draft technique, which is deflate and retract into the fenestration. So we're pulling the balloon back as we're advancing the retrograde guide wire. This was a retrograde Mongo wire that seems to be going outside. We had a lot of difficulty there, so we did an IVUS, and surprisingly, by IVUS, it looks like the wire might be true lumen, but clearly was not behaving like true lumen, and I think we were into the extra plug space. Not much distance, though. So eventually, with repeat attempts, we were able to advance the retrograde guide wire, and now it's going inside the guide extension. At this point, we could not externalize, and part of this is likely because we have a very tight bend. We have the wire going down, we have a tight bend. Also, we do have a ping-pong guide. It's best to have a second guide versus the same one for externalizing in patients that have ipsilateral collateral. So this is a 6 French EBU 375. This is the original 8 French EBU 375. But the externalization would not go. So what we decided to do is the tip-in. We brought the Antegrade Corsair, and then we advanced the retrograde guide wire. That was a Mongo that went very nicely inside the Antegrade microcatheter. So here is the retrograde wire tip. This is the wire inside the microcatheter stopping here. And then we pull back the retrograde microcatheter and advance the Antegrade microcatheter over the retrograde wire through the CTO all the way into the distal vessel. We then pull back the retrograde guide wire, and then we were able to advance an Antegrade guide wire inside the distal obtuse margin. Pre-dilated with a long balloon, did intravascular ultrasound, And then we placed, we did a little picture to see if we had any extravasation in this area where I was standing before, but now it was very faint, almost completely gone. So what we did is placed a 2.5 by 48 millimeter drug-eluting stent. And by doing that, this provided a nice result. We do have good flow. We do not see any contrast extravasation. The distal edge, there's a big step down that was a little concerning. We did essentially proximal optimization because of the size mismatch of the vessel with the 275 balloon, and placed a small 2.0 by 8 millimeter stent more distally. And then before removing everything, we want to make sure that we have access to the epicardial collateral with crossed, and also that we have access on both sides. So this is the Antegrade side, and this is the Antegrade side, this is the retrograde side, and then we inject it through the FineCross M3. There's no injury of the collateral, and then we're able to remove everything and have a nice final result. So to summarize, this was a CTO of the obtuse marginal that was deceiving because it appeared that there was a small channel. However, on the areocranial view, this channel was probably a bridging collateral with extreme tortuosity. So in cases like this, trying to go through this channel is not a good idea because it can lead to perforation. We did have some staining actually in our case, but then by going retrograde and using an extra plug technique, all that area was covered and there was no bleeding. We did an echo and did not show any effusion. When it comes to retrograde through epicardials, the typical equipment is a small microcatheter, Caravel or FineCross, and a very soft wire, the Suoh 03. It does take patience and small movements for the wire to get through. We had difficulty externalizing because of the acute bend. In this case, so we did the ping-pong technique, and we did the tipping, so advanced an Antegrade microcatheter over the retrograde guide wire that had been advanced inside the Antegrade guide catheter. We then advanced the Antegrade catheter distally and exchanged for an Antegrade wire. And finally, like many cases, when one strategy does not work, it's always important to promptly change to another strategy that can be more successful. Thank you.